Welcome everyone to our first learning session of the Cancer MDT Improvement Programme. My name is Dua Abdallah. I'm a Programme Support Manager and I work in the NHS Cancer Programme. We've also got some of my colleagues on the call. So we've got Matt Noonan, Robin Cutforth and Crystal Skinner. We usually have Alison Paul as well, but she's out last this morning. So our first session today is going to focus on streamlining. So we've got two streamlining sessions. We've got this one, then we've got another one in November. So just going through our agenda of the day, we're going to have the second part of the Designing a Successful Improvement Project with our colleagues from GOSH. We're then going to talk about NC streamlining, and that'll be Karen from Leeds. And then we will have Nikki Lawrence talking to us about MDT streamlining and the introduction of algorithmic aid. And then we'll be doing an action learning set at the end. So just the usual ground rules. So please do keep your cameras on. It's just a bit more engaging and more interesting to talk to everyone that way. Please do mute whilst you're not speaking. Please feel free to contribute any ideas, ask questions. You can use the hands up function or the chat box. And yeah, please do share experiences. Please do give your attention to the speakers and use the chat function thoughtfully. Feel free to, share insights, ask questions, provide links. We're all doing this program together, so it's really nice to be able to talk to each other that way as well. And you are welcome to also use the chat box outside of the sessions as well if you want to. And please do stay open-minded, be receptive to different perspectives and approaches from other participants. So, first people to present with us today are Nuwanthi and Caitlin from Great Ormond Street, and they'll be talking about designing a successful quality improvement project. And it's the second part of their presentation.
Thank you, Dua. Just gonna get up and running.
Yeah, and we can see your screen, so you're all good.
Perfect. Thank you. Good morning, everyone. So as Dua said, we are here for the part 2 of our quality improvement session, continuing from the welcome session earlier this month. So when I say we, it's Caitlin and me. Caitlin, do you want to give a wave as well?
Hi, everyone. Good morning. Really nice to be with you today.
Wonderful. Thank you. So if you didn't meet us at the welcome session, just to introduce ourselves really quickly, we are quality improvement coaches at Great Ormond Street Hospital, and we are very passionate about improvement and supporting others like yourselves on improvement journeys. So the last time we introduced the model for improvement, which is a widely used QI framework in healthcare. It's a simple yet, I could say, powerful framework for realizing improvements, and is a framework that we will be taking you through in this collaborative. It asks 3 questions. What are we trying to accomplish, which is our aim, and how will we know a change is an improvement, which is our measures, and what change can we make that will result in that improvement is our ideas. And then we use PDSA cycles to test the change in real settings. And for your MDT projects, this means starting small, testing your ideas and learning as you go. So the last time we covered the first 2 questions in this framework. And today we will look at the third question and testing cycles and some tips around sustaining your improvements. So as I said, the last time we go through those steps, and then we talked about how to write a problem statement, identifying your stakeholders, super important for your projects, and then looking at your measures. And we ended the last session with coming up with a SMART aim. And today we'll look at how to generate ideas. You've spent a lot of time understanding your problem now. So how to generate ideas now, how to decide which ideas to start with, or how do you decide which ideas are better, and putting those ideas to test. And finally, we'll go through some key considerations, making your improvement stick and it doesn't go back to how things were done before. So that's what we'll be going through today. So first up, generating ideas. Let's try to answer this question using a chat bomb. We did this last time too. Just to recap again, the idea is you type your answer to the chat, but you don't press send or enter, and I will say when you can press send. Please wait till then. I will give you 20 seconds to type your answer to where do ideas come from when you're thinking about an improvement project? Where do ideas come from starting now? Type it in the chat and wait. Yes, press send. Discussions of need, necessity, the teams, sleepless nights. Malini, absolutely.
Sleepless nights. Lessons learned as well. Yeah.
Staff involved.
Yeah.
Yeah.
Mm-hmm.
Service. Group discussions.
Problems.
Yeah.
Mm-hmm.
Brainstorming. Yeah. Problems
Other people's experiences. Sorry. Yeah, exactly.
I know. It's very exciting. Yeah. Previous experience.
Yeah.
That's really good. A lovely list is coming together here. That's great. Have a read, and if you can copy and paste this into your Word document or something like this, because it's really nice to take all these great ideas as you go. There's so much of experience in this room. So this is what we came along with. It really comes out in terms of how important your stakeholders are. So your patients, your staff, they could be great sources of your ideas as well, as you guys have already mentioned. But look around. Some of you had mentioned that as well, not just within your service, your hospital, but externally too, including other industries. How do they tackle similar problems, for example? So much resource that's out there for you. To do some really good idea generation, we would like to introduce a really effective tool at this point for brainstorming. Somebody mentioned brainstorming, so this is a really fun way, an effective way of doing brainstorming. We have taken this with lots of thanks from Shrewsbury and Telford Hospital. This is called 7 Ways. So when would you use 7 Ways? Not everyone can come up with ideas you need on command. I certainly can't. I need a bit of time. So 7 Ways will help with this a lot. It also helps colleagues to think beyond usual solutions by stretching their thinking. And it is particularly useful when you are focusing on an element of improvement and the ideas are not achieving the results that you're expecting, the same old ideas, for example. It enables you to obtain ideas from those who may not be confident to share ideas as well. So have a think if you can use this in your brainstorming sessions. So when using the tool, you will need to outline a few ground rules to get the most out of that session. The aim is to encourage creativity by escaping from the current ways of thinking about a problem. I think you can all relate to something like this, moving away from we have tried that before, or the answer is obvious, let's just do this. So it is important that we don't judge any of these ideas that comes along, and we are really, really open. And I also want to say at this point, pay attention to those ideas that give you a little bit of a laugh, because they may be those biggest leaps that you're looking for as well. So how to do this? First of all, pick a facilitator and then select the problem you want to find ideas for. So the problem that you started with at the beginning of your improvement project, what we talked about last time. Then rather than jumping straight to the usual ways of jumping into a solution, engage with your colleagues by using the 7 Ways method to generate more novel ideas. So once the team is fully aware of the problem and understands why it needs to be improved, then they can work individually to write down 7 ideas on how to solve them. This is not a limit, rather than a minimum, I would say. And the 7th idea might be the one that is the most progressive and will ultimately have that biggest impact, rather than the first few, which we have seen it a few times, be the ones that we have always tried before. So this is about stretching your thinking. So at this stage, the facilitator should remind everyone that no idea is a bad idea. They should try and be as creative as possible. maybe think of how others solve the problem, like, McDonald's, like airports, stretch. And once you have collected all these ideas, one idea on each post-it note, maybe, then the facilitator can arrange them into categories, and the team can then discuss and select the ideas that works for the team best. So that's a tool for you to take away from today. Having gone through that bit, let's look at why some ideas may be better than other ideas. There's no idea is a bad idea, but some ideas are better than the others. So at this point, we want to introduce a topic called sticky ideas to you. And this concept is really good at helping determine if your idea will work or not. So what can we do to give our ideas the best chance of sticking? Everett Rogers, who is a professor of rural sociology, did a large study to understand how ideas get adopted. So Rogers suggests that we assess them against 5 key characteristics to test their viability to help with engagement. So look at the screen to see how some ideas have really stuck and others have been replaced quite quickly. Some of you may remember the bendy buses in London didn't really work for the sizes of the roads that we have in London. It was cumbersome, didn't really fit through the London roads, causing congestion, for example. So got taken out quite quickly. And the Blackberries that we can see on the screen got replaced with the touchscreen phones quite quickly as well. So with that in mind, let's now look at the 5 key characteristics to consider. They are all equally important. One is not more important than the other. They are equally important. If your ideas show a high degree of these, there's a better chance of it sticking. That's the concept. So first up, relative advantage, and this refers to the degree with the innovation is perceived as better than what it supersedes. So is it safer? Is it more effective? Can you articulate the benefits for the patients, for your staff, for example? It gets adopted better that way. Next up, compatibility. And this is how well your new idea aligns with the existing ways of work, existing values, past experiences of people, and needs of the users. Is it close enough, and can it easily be integrated to the current ways of work? If you find something that's completely different from our current ways of working, it might be more challenging to get it adopted. So the next one that we have is simplicity, or the ease of use. Is it easy to understand this bright new idea you came up with? Can you easily explain it? Can the instructions can be easily followed, for example, and the clunkiness of the use, for example? The more yes you say, it is a better idea. Observability, this means the extent to which the results of this idea can actually be visible to the others. For example, can we demonstrate this working elsewhere? Can we show some data, perhaps? And the last one on the list that we have is the trialability. And this is the degree to which that idea can be experimented on a limited basis. So think about how demonstrations and trials work. We like to say yes to something if we can experience the benefit before committing to it fully sometimes. So those things are the 5 key considerations to decide if your idea is going to stick or not. And over to you, Katie.
Great, thank you so much, Noati. I'm now going to take us through the final 3 learning objectives for this morning. So the first one, I'm going to cover prioritize your change ideas using a benefits matrix. So now that we've got all these ideas, as Noati's just taken us through sticky ideas, but also 7 ways to generate ideas, how do we prioritize them? Because in some cases, we're not going to be able to test and implement all of these great ideas, especially in the case where we've done maybe some idea generation works and brainstorming, and we've now got a whole heap of ideas that are in front of us on the table. So we need a way of prioritizing our options so that the ones that are the easiest to implement but have the greatest impact are tested first. And we can do that through a benefits matrix, which is a framework to make informed decisions. We can assess solutions for their impact against the effort required, and it's a quick way to filter out solutions that might not be worth the effort. So how a benefits matrix works, you'll see on the x-axis here, we have the ease of implementation or ease of testing. So I've gone back, ease of testing. And on the y-axis, we have the benefit. And what we need to do is assess all of our ideas against these criteria. It's really important that we do this activity with your project teams or with a group of stakeholders, and we don't do this in isolation, so that there should be a shared agreement on where your idea will fit on the benefits matrix. And once we've done this, you'll find that your ideas will fall into one of these 4 quadrants. And they are quick wins, challenging projects, nice to haves, and don't bother. So by evaluating the attributes of each option, we're quickly able to identify which ones to test or implement first. And we'd recommend that you start first with ideas that fall into the quick wins. So that means that the ease of testing is high and the benefit is also high. So this is really where we should start. We then follow that by challenging projects, and that's because the benefit is still high, but maybe the ease is a little lower. So we might find there's more difficulties getting the right people involved, or there could be some other challenges of getting this test off the ground. But really important that we then tackle challenging projects after quick wins. Nice to haves are quite an interesting one. I think that this can be useful as maybe an engagement or strategic sort of decision to try out some ideas that falling into nice to haves, especially if you've got maybe a key member of your project team whose idea falls into nice to haves, and you want to keep them engaged and you want to keep them on board. So sometimes we do try out nice to haves as well, but generally more for that sort of just strategic decision. And anything falling into don't bother, we need to discard these. Or what we could also do is go back to the idea and maybe try to refine it, improve the idea, to then make it fit into a quick win or a challenging project potentially. And we want to ensure that it does that. So the benefits matrix, just to recap, it ensures resources are directed to those solutions which have the greatest impact and are the easiest to implement. And it's a really fantastic tool. We use it really frequently in our improvement work. I'm now going to talk you through how to use PDSA cycles for tests of change. And almost every organisation, whether it's private or public sector, tend to react to a need for change in one or two ways. So we might firstly see that an incident has happened and you need to put a quick fix in place as soon as possible. And that's where we see this sort of firefighting method come in. And I'm sure we've all of us in this room have experienced that in one way or another in the NHS. It really is so common, that firefighting. We don't have enough time, but then there's sort of too much action and maybe not enough thinking. And usually the original incident resurfaces a few months later if we've only gone down the sort of firefighting method. The second is that we spend too much time thinking about how to solve the problem that nothing gets done. So we fall into this over-analysis or paralysis state. And what happens there is something with greater priority comes along and takes its precedent, and we don't address it in the right way. So these two methods are really common, but we can overcome these by using a third method, which is our PDSA cycles, which I'm going to talk you through now. So PDSA, you'll remember, it's really key in the model for improvement. It's that third aspect. And that PDSA stands for Plan, Do, Study, Act. And it is used extensively across the NHS and the healthcare sector today. And it's an approach of continuous improvement, and it's iterative, meaning that you keep repeating the cycles. It helps to break down a problem or an improvement initiative into manageable, bite-sized chunks. It's all about quickly assessing potential solutions for small scale change before implementing. It's really important. We do this before an implementation. And the benefits of using PDSA cycles within your MDT improvement projects is that you can test changes on a small scale, meaning that they can be done quickly and with minimal expenditure of resources. Therefore, you're not investing lots of resource into an improvement idea until you have evidence that it works and that it's resulting in a positive change. We also find that PDSA helps us get staff buy-in or stakeholder buy-in to a small scale change where they can really clearly see the evidence of whether it's working or not, and they can actually be part of that test to understand whether it's working or not. It's a really engaging tool before you move to kind of a full implementation sort of decision-making state. So it's all about experimentation, not implementation. So the individual stages of the plan, do, study, act cycle, we start with the plan. And really try not to skip this section. It can be tempting to just jump into the doing, but it's absolutely fundamental to set up the test. And this will help us get the rest of the process really clear. And we want to be quite intentional at this stage as well. So thinking about the improvement, the outcome that you want, how you'll measure, and what you expect to happen is really key. And spend just enough time planning. Try not to, you've got to find the right balance of not over planning or under planning. There is sort of a balance there, which takes some nuance. Then you go into the do. So you just carry out your test, go for it, observe it, do the process and perform the test and see what happens. You then move to the study phase. So you review any data that you have. And here, don't forget the importance of qualitative data in this step. So talk to people who are involved in the test, collect their feedback. That's really, really important and is part of study. And then if you have any other data, of course, have a look at that in this stage as well. And how well does this inform your understanding of the process? And then we move to act. So what will you do now? Will you adopt if it's worked well, adapt if some changes are needed, or if it's not been a successful test, we can just abandon at this point, which is absolutely fine. This is what we call the theory to improvement, and really it's just demonstrating here we can move from our theories, hunches, and best practices through our iterative PDSA cycles to eventually reach that state of improvement where we know that our change has resulted in an improvement. There's a video that we're going to circulate for you. We won't cover it today. It's a really interesting example if you'd like a kind of healthcare-based example. It's around discharge planning. So we'll share that with you after the session. So our top tips for PDSA: think big and test small. So really take that on board. The test should be really, really small to begin with, your first PDSA cycle. So you're looking in one clinic on one day, one service. Really contain that test. Test one idea at a time. If you can record your cycles using a PDSA log, which we can share with you. This is a great sort of phrase that we like to use with PDSA: fail fast, learn quickly, and you're not your idea. So try to look at each idea without biases and use tools such as sticky ideas to help you assess ideas for their impact. And our final learning objective: understand how to sustain your improvements. So once you've successfully completed your PDSA cycles, you need to ensure that there is a sustained improvement. And these are our top tips for sustaining improvement. Document your change. This is really important. So any new ways of working, you turn this into a simple SOP, or is it sort of a clinical guideline, or is it a how-to guide, depending on what your change is. Make sure it's documented. Ensure relevant staff have been consulted and are communicated about the changes. So you want to think all staff and the relevant stakeholders who will be affected here. You need to make sure staff have been trained in the new ways of working, and you want to monitor your change on an ongoing basis. So how can you do that as a regular thing? Always going back and checking that change has made a sustained change over time, a sustained improvement. And for change to be sustainable, it has to be a joint team effort. So it's a joint team effort with frontline staff, senior management, and supported by standards and governance. And that brings to a close our 20-minute session with you this morning with part 2 of designing a successful quality improvement project. And our QI one-to-ones have been kindly scheduled by the team, by the MDT improvement team, and these are starting in early November. So you'll meet either myself or Nawati or potentially another member of the GOSH QI team. And we're really looking forward to meeting with you then and being able to talk through your individual projects and improvement ideas and support you with those. So we'll be seeing you then.
Wonderful. Thank you so much, Namanthi and Caitlin. That's brilliant. Does anyone have any questions for them at all in the meantime? No, well, yeah, you'll have your sessions with them, which is really great. And I think I really empathize with the either firefighting or over analysis is such a big thing. And I think it's so prominent in our professional and personal lives. So yeah, I think it's great to see a different alternative to that. So thank you so much. And next on the agenda, we have Karen Henry, who is a Macmillan lead cancer nurse and coming along from Leeds Teaching Hospital to talk to us about MDT streamlining. And we are also going to share Karen's slides.
Thank you so much, and thank you for having me. Yeah, I'm just going to talk through our approach to MDT streamlining that we've taken in Leeds. We've probably been at this now for about 2.5 years, so it's been a work in progress. I don't know whether it's easier to people to just save questions till the end or put them in the chat, and then I'll try and answer anything at the end. So the case for change, this won't be new to anybody. We're obviously seeing an increase in the size of our MDTs, more patients needing to be discussed. They're often much more complex. And our meeting times haven't changed, but the number of patients that we need to discuss in those meetings has changed. So we've constantly got meetings overrunning, next team banging on the door to get in. And within that meeting, we know that those complex discussions are not always having the amount of time they need. The level of information that's available, we knew from the start that not all the information is there, which makes it difficult to make a treatment decision. We move people on a week, which is never great. You know, there are patients sat behind this who are waiting. They know there's an MDT taking place and they're waiting for that answer. There's real variation in how the meetings are run, how they're prepared, how they're chaired, who gets involved, who doesn't. There's often a lot of people in the room and only 4 or 5 talking. And there's real variation in how the outcomes are recorded. Some of our MDTs have live typing taking place, others have people dictating. The remote members, we're a cancer centre, so we've often got specialist MDTs with people dialing in remotely who can't see if it's being live typed. So a number of issues that kind of make us want to look at how we do something differently. So next slide, please. So what did we do? So probably about the April of 2023, we'd been trying to do things before then, but we changed tack and decided to do something different. And we identified 4 MDTs to work with. And one of our quality improvement leads spent quite a lot of time with the MDT coordinators for those teams and really understood what the process looked like for them and what the issues were from their point of view. And then between myself and Kath, who was our service improvement lead at the time, we went into each of those MDTs 3 times and we observed and we recorded what happened. And I'll tell you how we did that in a minute. We also sent a survey out to all of the staff within each MDT meeting, asking for their opinion of how they thought that MDT ran, what was positive, what could do with some change. And we got some patient views. So we have a Maggie's Centre in our grounds, and we went down to the Maggie's Centre and we talked to patients about MDTs, and that was fascinating about what patients think an MDT is and their thoughts on that. And then at the end of doing all of that for all of those 4 teams, we took the staff out So we asked for a representative of every member, every core member, so a radiologist, a pathologist, a surgeon, a physician, whatever it might be, a nurse, HP, and we took them out and we had a half-day workshop to feedback everything we'd found. Next slide, please. So the way we observed the MDT, we used a tool called MDT Mode from Imperial College in London, and it records the time, it records the length of each discussion, but you also score what's presented. So is there, from a radiologist, are there images presented? From a pathologist, are they presenting anything? Are they sharing reports? It looks at the chairmanship. It looks at what kind of information is presented around comorbidities, around the patient's psychological, social situation, what kind of background is presented as the person who's giving that information starts, who speaks, who contributes, what that level of contribution is, and does a decision get made at the end. So there's a picture there. When we started, we were doing this by hand, and then we got a bit more whizzy and started doing it electronically as we went along. It's quite hard to do, to be timing it and also timing each discussion, and also kind of, I think we realised you definitely need to be clinical. We had a couple of colleagues who tried to do that, and we realised they were just not picking up on some of the nuances that Kath and I were. The survey, we just used a tool like SurveyMonkey that went out to all the staff, and then I've mentioned we went down to Maggie's to get that kind of patient view. Next slide, please. So once we'd gathered all that data, our quality improvement lead pulled for each MDT, they pulled all of that together, and we presented it in the room that we used for the timeout session. We presented it as a data wall. So each MDT had a huge set of data up on the wall that fed back all those observations. It fed back their survey results from their staff survey, and also for each team we shared the patient views. And we got everybody in the room, and the first thing we did was we just said, go and look at your data. Be really curious about what you see, what surprises you about what's up there, what are you not expecting to see, what rings a bell, and we gave them a really decent amount of time to do that. And then we asked them to review another MDT's data. The same thing, go and have a look, be curious, and also think about how does that compare to what you've just seen around your own MDT. And then we asked them to feed back. So they fed back on their own MDT, and then they also fed back on the MDT that the other MDT that they'd had a look at. And that was really, really useful for the different teams to kind of have that outsider view on their own MDT. And then in that afternoon, we had some time then for them as a team to sit and think about what would make a difference, what did they want to do, what changes could they make, and thinking about what colleagues from GOSH have just talked about, thinking about all those kind of quick wins, what might be longer, what might be more difficult. Could you introduce a standard of care? Are there patients that the outcome is, oh, if we do this and we do that, we're always going to do that next? So they had enough time in that session to start to think about what they would do, and we asked them to present that back as well. So we kind of had a nailed down, this is what we're going to try as a team. And then following that timeout session, we followed up with each of those teams to kind of get more specific actions put down that they were agreeing to undertake. Okay, so what's changed? So as I say, we've been at this for nearly 2.5 years, just under. It takes time. So we're about to run our 4th timeout session in November with 4 more teams, which will mean we've had 16 teams go through the process. And what we've learned is that it's different for each MDT. There is no one size fits all for this. You can't go in with an expectation of, right, every team, we want you to introduce 2 standards of care and we want you to do this and this. That really doesn't work. Some teams, so one of our first teams was colorectal, and the lead clinician at the time was a radiologist, and he will not mind me saying, he stood up and said, we've got some really basic stuff to get in order before we can even think about a standard of care. And they're actually one of the teams, and I will talk a little bit more in a minute, that have come the furthest. But on that day, that individual stood there and was like, it's just made me think about the enormity of what's ahead of us, because we've got so much that doesn't work. Whereas other teams, we had, I think prostate were one of our first teams, their meeting ran really efficiently, but nearly every patient they discussed, they already knew what they were going to do. So they were like, yeah, we can absolutely write a standard of care here. So it became clear really quickly that there wasn't a one size fits all. Each team were at a different point in their MDT and had different things to do. What we have done is I wrote this presentation a little while ago. We've got more than one set of standard of care, but we had one, the prostate one, bladder, approved at our Cancer Alliance and had been through our trust process for sign off. We've got about 4 or 5 more standards of care being worked on. Alongside all of this, we involved our digital informatics team, because one of the biggest things that was coming out from everybody, and particularly from the MDT coordinators, was the level of information that came as part of the referral into the MDT was often inadequate. The MDT coordinators were chasing things. We were having to pull rather than the referrers pushing information. So digital information agreed to work with us on developing electronic referral performers that would sit in our IT system and that would have fields in that had to be completed before that referral could come through. And we got to a point where teams were having had to kind of, it felt like pulling teeth to get people to join. We had people going, oh, could we go next? Could we be in the next cohort? So there was a definite, and we knew that that would happen. There was that swing of people kind of seeing the positive changes that were happening in the MDTs we were working with, and wanting to take part and be part of this work. Next slide, please. So some of the specific changes. So as I said, the colorectal were one of our first teams, and the lead clinician was like, oh wow, you know, we've got so much work to do. But what they took away and decided to do was, I think most MDTs have to have a development meeting once a year, some twice a year. But what Damien wanted to do was set up a colorectal tumour board, and he managed to get that up and running. They meet every 2 months as a representative from every member of the MDT, and it really has created momentum. And the changes that they want to make and things that they want to do within their MDT, they meet for an hour and a half to 2 hours every 2 months, and they're moving things forward at pace. They put in a bid to have a colorectal fellow that was successful, and he looked at some standards of care for the anal cancers, and they've radically changed the way they manage that, which has reduced the number of MDT discussions. They've changed the way they chair the MDT. They've changed the order in which patients are presented. So they've done a huge amount of work, and it's taken time. But probably from the lowest starting point, they're one of the teams that have done the most. Again, our brain tumour MDT, they changed how they were chairing their discussions. They changed the order in which patients were presented in. They stopped discussing. There was a group of patients that the low grade patients, they stopped discussing some of their low grades. Within our gynae MDT, it's a specialist MDT, and there was a recognition that they were discussing. So all the other district generals in our patch have their own unit MDTs, and they only send in to the specialist MDT those that require that input, whereas all Leeds patients were going through the specialist MDT. So there was a recognition that they needed a Leeds unit MDT to reduce that larger central one. That's been up and running for about 6 months now. Sarcoma and another MDT, they didn't have a cut-off for their pathology, which meant sometimes radiology were prepping cases that they couldn't be discussed because the pathology wasn't ready. So they've introduced a cut-off, and 3 of our MDTs stopped discussing benign patients. So we've seen some, as I say, real different things happening, but all resulting in a reduced number of cases going on the MDT, allowing for kind of those more complex cases to have that longer time, and also that fatigue of, some of the MDTs were 4 hours long. That's a long time to be sat in a room, and if you're patient 49 of 50 and you're really complex, have people still got that energy they had 3.5 hours ago to be discussing your case? And that was the real driving force for the clinicians to want to kind of have that time for those really complex conversations. Next slide, please. What has been difficult? So writing standards of care, the clinicians have found not too challenging, but actually then working around job plans to implement them is a major challenge. If you're going to put in a standard of care, you need to triage the patients who are being referred in, and that needs somebody to do that. And everybody recognises how important that is, that actually if we do this properly and we triage people and we don't put as many patients through the MDT, we improve their pathway, we speed up their pathway, they get to the next step faster rather than waiting that week for an MDT. We make the MDT shorter, giving people more time for those discussions, but that requires someone to do that triage outside of that MDT. So we have found that that's been a sticking point. And we're finding different solutions. Again, there's not a one size fits all to making that work in the different MDTs. There is reluctance still to change the status quo. Some of our MDTs are still very much, we're all good, thanks. This is a great MDT. We don't need to do anything different. That's really challenging to change, and that's a culture thing. Some of the MDTs absolutely recognised that patients were being put on because it was an easy way of getting a job done. So an internal referral from clinical to medical oncology, or if they put them on the MDT, it meant that the scan might get reported faster. So it was people were being put on who didn't really need a discussion. And so we've had to find alternative means for doing those jobs where it's been a workaround to put them on the MDT rather than actually finding a way of doing what needs doing outside of the MDT. And getting the digital resources right. We are still ongoing with getting our digital resources right. That's a work in progress, but we're getting there. So yeah, that's me. If anyone's got any questions, I'm very happy to answer them. If people want to email me, I've put my email on there. It has been a long process. It still is. We're still in the middle of it. We've probably got another 8 to 10 teams to do, but it does feel like we are getting somewhere, and people are making changes.
Thank you so much, Karen. Really, really appreciate the presentation. Matt, did you have a question?
Yeah, thanks so much. It was really interesting. I'm just interested so you sort of alluded to the fact that people are starting to ask to come in now. What, in terms of like how you've set up this program, have you got a sort of governance structure where you're having regular meetings? How have you made have you sort of, I guess, kept people to task? Because it sounds like it's been really effective over the last 2 and a bit years.
Yeah, we've done it through. So we've used a number of different meetings. We've met individually with the MDT teams and kind of kept on top of them. A number of them have got transformation programs up and running wider than just MDT streamlining. So where we can, we've incorporated MDT streamlining into that. We've used our cancer board we've had it as a regular kind of item on our cancer board agenda, and we have an MDT lead clinician forum quarterly as well. So we've been putting it through there as well. So it's been kind of multiple. We've had to set up some governance in terms of how we sign standards of care off. So we took a paper to our quality assurance committee around the work we were doing, and asked for their kind of advice and support in how we sign those off, and we've got a process set up for doing that now. Yes, it's been a bit of kind of working with individual teams. We've got a spreadsheet that we keep with all the changes that teams have agreed to do, and we go in regularly and kind of go back and natter people and update, and then update that on a regular basis.
Yeah. I mean, it's really interesting. And do you sort of that spreadsheet, I guess, is thinking back to like the initial challenge we had earlier on about where the ideas come from. That sounds like it could be a bit of a goldmine for for sharing across your MDTs internally in terms of is the people are people like learning from each other?
It's on SharePoint, so people can access. We look all our cancer documents on SharePoint. We open up to anybody who wants to access them.
Right. Cool. Thank you, Karen.
Wonderful, thank you. Any other questions, Laura?
Hi, Karen. Thank you. You mentioned just towards the end of the presentation about trying to sort of streamline discussions and think about forums where you could consider some of the referrals outside of the MDT. I just wondered what you actually did with that, and what sort of extra meetings you set up and how you managed it within existing job plans.
So it's a really tricky one, because I think there's a recognition that if somebody's doing that triaging, we've had lots of suggestions from the clinicians that this could be done by someone else, often CNSs, even wondering if it's really well protocolized, could it be done by a non-clinical person? But I think in the first instance we've been fairly keen for this to be done at kind of medical consultant or registrar level, or possibly an ACP. And so we've had to work with our different clinical service units, their kind of management teams, to say, can you look at this individual's job plan? Because some of the smaller teams, it's like if the results are coming in, people have been in colorectal, for example, when the clinician was like, look, I can take 15 minutes a day and I can have a quick look at what's coming in, and I can send that either back to the MDT coordinator team saying, yeah, that's for MDT, or that's for, straight to clinic, straight to whatever. Other teams are looking at actually carving out time in one of their ACP's job plans to do this triage of against a standard of care. And I feel like we're still learning on this. What we have said is, so in the bladder team, they were going to double run it. So we were still going to put people through the MDT. The triage would happen outside of the MDT, and then we were going to put them through the MDT for a 3-month period and make sure that we were making the same decision, that the standard of care was working, that we're making the same decision in the MDT as someone is making triaging that patient against a standard of care. And then we've said for anyone who introduces a standard of care, there needs to be a twice-a-year spot check audit against the decisions that are made outside of the MDT. So I feel like this is still very much, we're learning around this, and this is definitely one of the biggest blockers, is working out how to do that triage outside of the meeting. But we had a really good discussion about this at our cancer board last week, and there's starting to be a recognition from our senior team of execs that our MDT clinicians need more time. Their PA allocation was done in 2016, and it's not worth the paper it's written on. So recognizing that we're asking them to do more and more, and this particularly, someone has gone away to look at kind of what does that need to look like if we're going to make this work properly.
Brilliant. Thank you so much, Karen. Thank you so much for coming along to present. If anyone has any other questions, feel free to pop them in the chat box, and Karen has shared the email address, and we will also share it at the end as well. But yeah, thank you so much, Karen. So next up, we have Nikki Lawrence from Royal United Hospitals Bath coming along to talk to us about MDT streamlining as well, and the introduction of algorithmic aid. Nikki, you on the call?
Thanks very much, and thanks, Karen. That was really interesting. I mean, from the work you've done, which is very wide and broad ranging, to become a bit more specific about what we've done in terms of the breast MDT at the IUH. So I'm a oncoplastic breast surgeon. I probably a while back now, when streamlining was first introduced, took on this change, because going back to why do you first talk, how do you find when you want to make a change? And it just frustrated me, the MDT, and I saw straight away after I'd been to that meeting that there were so many changes that we could make. So next first slide actually. Can you move the slide, or am I supposed to move the slides?
Oh no, Dara, we're just having some technical issues. It's always the case, isn't it, when you want to share your slides? It's just like, no.
I'll just I'll give you a little brief background. So having been to talk about standards of care, our MDT had a slightly different approach to the standards of care, and having a separate MDT, probably alluding to the problems that you've been having, Karen, is that how do you have that separate MDT, or that's those people that are choosing to do that. So rather than having that difference, we said, well, let's just put them all in, but do a lot of preparation beforehand so that we can put the outcomes in for all patients, and then ratify them. So a lot of work's done prior to our MDT. So this is our weekly pathway. So we use the first thing was our MDT list was a piece of paper on a wall, and people physically wrote in the patients every week. So we changed that to an MDT list on Teams that's an open access all the time. Anyone can put patients in. You can put patients in at the same time. You can't, it doesn't allow you to fill a box that somebody else is using at the same time. So anyone can use it at any time on any computer, as long as you're logged onto Teams. And then we had so we decided one senior consultant would be given 5 hours of time to prepare the weekly meeting, which can be up to about sort of 70, 80 patients. And we chose that one really senior consultant, who obviously is very expensive, but felt that they would have most of the knowledge to make sure that all the pathways were as accurate as possible. So countering what you said, where people weren't giving enough information, we sort of gave up on people giving us enough information, and we tasked that consultant surgeon to get all the information that would be appropriate to have the discussion fully within the meeting. And we have got really good digital systems. So we use Cerner Millennium. It works really well for us, and we're a paperless unit. So all of our information is on really good digital systems, so easily accessible, and a lot of the surgeons do it at home. So they produce provisional plans across the board for all patients. And then, so the day before, these are all distributed to everybody, and the MDT coordinator will put in all the information, including all the outcomes. And those provisional plans entered into the Somerset Register. Then when each patient is brought up, a lot of those patients are very straightforward, would be what you might call the standard of care. And then you're just literally looking at all the information that's there, and then the oncologist would say, yes, that's fine. And then, so the time taken for those simple patients was not huge, but meant that you didn't have time outside with people deciding who's separate. But also sometimes you think that they're not straightforward, but they think they're straightforward, but then they're not. So it would give an opportunity for someone to go, actually, can I just say something here? But it did shorten the period of time, which meant we had longer time for those complex discussions. And then at the end, our outcomes are distributed on a Word document, and they go into the patient record on Cerner Millennium. The next slide, please. Do you want me to answer questions now? I'm happy to. Max,
whatever you prefer, you can do them at the end, or you can do them now. It'll be up to you.
So, Max, do you want to?
Yeah, it's your choice when we do it. But just on your previous slide, it's really interesting to me, and very good how you've done that. I'm just trying to get my head around how we, for a long time now, every single cancer patient has to be discussed in an MDT, and that's the red line that we all need to hit. And it just seems like we're now slightly going backwards with, you know, we do streamlining too. I can absolutely see the efficiency benefit of it, and your pre-planning looks like a very significant, very valuable piece of work for one experienced consultant to do. But I mean, to what degree is everything just turning backwards to us saying every patient needs discussion in an MDT, but we're going to find as...
Shall I carry on? Let me carry on.
Yeah.
Ask me at the end. I'll because you might have an answer as we carry on.
Okay, that'd be great.
That's okay. So this is our MDT on this is our team list that we do. Everyone's got a section. So if they're post-op malignant or they're oncology discussion, you just choose which one it goes into, and then at the end it's all ordered so that we have an order where we do the more complicated patients first. We let oncology go, and then we do this with benign things at the end. So next slide, please. So this is an example of one that has been filled out. So there's a reason added, so we make sure that we know exactly why the CT scan has been requested and why we're discussing it. And then the results, so the post-op histology or whatever, and then the plan is put at the end. So I put reason added. So next, there's the plan, that red arrow, and then those are fed in by the MDT coordinator. Next slide, please. Into those arrows, if you click and click, will go reason added and then the plan. So those are put in from the MDT list, and that's, I don't know who uses Somerset Register, but that's our Somerset Register pro forma, and it goes into Cerner Millennium. This is the patient records the next day. Next slide, please. Okay, so maybe this might answer your questions, but our MDT for breast has got really complicated. So we've got, but we also have quite nuanced treatment pathways, but with tight eligibility criteria. We've got more treatments for those patients with worse disease. So there's a CDK4/6 inhibitor that we can give, PARP inhibitor, so olaparib we can give, and they're quite tight criteria. And sometimes you're going back to those criteria. Oh gosh, is it a T3 or an N1, or is it T3-1C? So a bit more complicated, but we're also de-escalating some treatments. So those patients who we were told were simple actually now become less simple, because maybe we don't need to give as much treatment. We used to standard everyone who had a breast conserving surgery, so a wide local excision, would always have radiotherapy. Now you might give them partial radiotherapy, or you might even omit radiotherapy, or you might try and avoid chemotherapy by doing an Oncotype DX score. So as we looked at our standards of care initially, those have changed as we improve our treatments. We've also got an unbelievably complicated pathway for family history, which includes looking at patients' relatives that when they had their breast cancer, and one for a PARP inhibitor, R44, again complicated. So the result, all of that, was increased time to prepare the MDT. We're making omissions and errors. So next slide, please. So we thought, well, because a lot of these are based on very similar parameters for breast cancer, but lots and lots of outcomes, we thought, well, if we have a program where we input all the data from every patient in terms of their TNM staging, their age, their postmenopausal, their post-op data, and then maybe we combine, I don't know if anyone's a breast surgeon here, but we use something called Predict Breast to help people decide whether or not to have chemotherapy or not. So using that sort of simple, those data to then have some outcomes that will tell you what the outcome should be. So next slide, please. So this is an example of some of the parameters that we use for breast cancer. So there's not that many for the outcomes that come out. So ER, PR, HER2, whether it's invasive ductal or lobular. Next slide, please. We also, for the patients that come, to all our patients, we have a digital pro forma. It's sent to their home or to their computer, and they fill out their family history. And it's very prescriptive. It's not, do you have any family history? It's who is it? So is it maternal or paternal side? And then it says my paternal cousin, and then it'll ask them for an age. So very, very specific drilling down, where they're not really having to think that much, or having to, the information is asked in direct questions. And we feed that all into our algorithm. Next slide, please. I don't know if you can see that. These are the outcomes, or the but statements. So for those patients, say you're going to have partial radiotherapy. So you have to have had breast conserving surgery. You have to be over 50. You have to have had invasive ductal cancer. You have to have no nodes positive, T1 tumor, ER positive, and so on and so on. And if those are all fed in, then it should feed out the other end that you're eligible for partial radiotherapy. And for every outcome, so whether they have chemotherapy or ribociclib or tamoxifen, or all those will come out the other end. Next slide, please. So this was the thing that really broke me in terms of change. This is the algorithm for a PARP inhibitor, which is just really complicated. I don't know how many people are abreast, so I'm just going to move on from that. So this is, so I worked with some computer science students at the University of Bristol who have a second year project. They weren't paid, it's part of their module. So I was given 4 students, and I went to them with my Excel spreadsheet and said, can you do this for me? Because it's pretty simple code. So what they developed is, this is a sort of a prototype really. So next, this is your first page, next slide. So you have just patient information tab, so their name, their date of birth, exact, etc. Those parameters that I showed you on the Excel spreadsheet would be filled out this for a pre-op diagnostic stage. So next slide, please. We put in the family history data, so a cousin, whatever age, the patient at whatever age. It'll tell you their Manchester score. Next slide, please. And then when you click the Analyze button, it will tell you that this patient can have VESCO, they need a pre-op stage CT scan, and they are eligible for mainstream testing under R208. Next slide, please. Similarly, when they've had their surgery, put in their post-op diagnostic information. Next slide, please. And then you press the button, and it'll tell you that they can have, they need to have an MRI scan afterwards, they can have adjuvant VESCO, staging CT scan, radiotherapy, and tamoxifen. Next slide, please. So where are we at? So this is a minimal viable product. I want to scale it up. I've sent it to some hospitals, but there are some issues with it not working on a Mac or an NHS computer. I've had loads and loads of there's been a long journey talking to lots of people to enable it. So going back to you, Max, in the long term, I would hope that lots of the things or the decisions that are made through the breast MDT are supported by this as an algorithm outcome. And that's me.
Wonderful. Thank you so much. Does anyone have any questions? Krishna.
Thank you. Very nice presentation. I think just a couple of comments. I think one is with regards to what you talked about in terms of the MDT database. And I think predicting outcomes is what I understood. So there is a lot of work that is being done, and actually we've put in for a 3 million grant for AI generated MDT outcomes. If we get it, obviously it comes with a lot of resource, because one of the problems you have with taking it to a few students to help you out with a data sheet is that is not a consistent long-term sustainable process, because you may get good people who are willing to do it, and you may get people who are not willing to invest that time. And obviously the accuracy of the data does matter, what goes in there. So that's the first thing. And I think, how you circumvented that. And secondly, I think it has become much more arduous in terms of preparing for an MDT. We certainly at King's are struggling to get consultant time to do that prep. And what we do is the consultant helps with some of the triage, but it's the fellow who preps the MDT, because there's just no time in the job plan for preparing an MDT and taking out 5 hours, as somebody said earlier, in trying to invest time for prepping it. But there's no question, if you prep it better, you lose or you make it more efficient functionally. So thank you for the presentation. So
to answer the first question, so going back to the very first presentation about doing something small, and this was to produce a minimal viable product to show how things can be developed in the future. So this is their project. It's done for no cost, but you can see how it works. And the future, again, that you can use multiple visions within this and extending into AI would be for a grant and for proper coding, because this is a basic code. It's open source code. I can give it to any of you and you can all copy it. As I've developed it over the last 2 years, every time I've sat on an MDT, worked out, oh, missed that. So it is what it is at the moment, which is what we use. I haven't got ribociclib in because it was coded before introduced it. But the long-term aim would be that you'd combine with ABS, and that they would up for every change you'd get a change. And this is just algorithms, it's not AI, but you could in the long term code it so that AI would read all the new guidance and update it directly. So this is a minimal viable product. It's to show how things could change, could work. I initially just wanted it for our MDT, but I've had some
1.5.
Okay, thank you.
So going back to the preparation, so I personally feel that if your hospital will give you 5 hours for your most senior consultants to prep an MDT, once we do it 1 in 4, the cost saving for all of those people that are sat in an MDT is obvious.
Yeah, thank you. Sorry, I'm not putting my camera on, not being antisocial, but
That's
it's about
okay.
8 hours of the morning where
That's
I am.
okay. Good luck with your 3 million grant. I hope you guess it.
Thank you.
Thank you.
Francois?
Hi, I've got a question. Thank you for your presentation. It's given me some ideas. My query is, how do you, so part of your MDT, you, which I do like, is that you essentially make a decision before, you come up with an idea, a plan beforehand, and in your words, you use the word ratified.
Sorry, go on.
Your words, you use ratify. I have members of my MDT where the very idea of me saying we make a decision, some form of decision that gets ratified, or I think the rubber stamp is the word that irks this person. How do you influence this other people who feel very strongly about all of us having an MDT about a problem that's, we all know what the answer is?
Sure. So just can I ask what MDT are you in?
Colorectal cancer.
Okay, so it's been a while since I did colorectal cancer. Most of the of our outcomes in breast are not an idea; they are very standard guidance. When I first said or put it to the team that we were going to do this, my first worry was that everyone would just switch off and fall asleep and not engage. Actually, it's the counter argument, which is actually what you want is you want standard. So the equivalent of a standard of care, and then you want discussion. So your colleagues, you can use your words in different ways. You're saying this is the standard of care. How do we feel that this patient should have something different? And you're developing discussion. It may be that in colorectal you don't have standards of care in the same way that we do in breast, but so much in breast is very algorithmic. There are eligibility criteria for all things.
We do have some standards of care. It's just that some people feel very strongly that they want every patient to have the same amount of time being discussed about a problem that, or whatever.
That's ridiculous. All I'm suggesting is you put all the eligibility criteria up for the patients that's in guidance. That's what the Cancer Alliance wants us to do, to make sure that everybody is offered what is what the people who spent all the time to decide that's what they're eligible for. But the reason we haven't taken them out is that we want that people to be able to say, actually, this is standard of care, but for this patient, for this reason, I would challenge that I would like this. So you're not wasting time with your MDT coordinator typing as you are typing. They're basically deleting. And I often, when I'm doing it, I'll write this, but query, should we do this for this reason? And often I'm discounted and we delete it, or sometimes it's included. And other people put things in because they're more engaged, because you're not wasting time going, do you want to give endocrine treatment to this person with an ER positive breast cancer, which we all know, and then they're writing endocrine treatment. It's gone okay with us.
Wonderful. Thank you so much, Nikki. I really appreciate your presentation, and we'll share your email address and the slides as well. If anyone has any more questions, then feel free to pop them in the chat box as well. So the next thing we're going to do is we're going to do an action learning set. What we're going to do is we're going to assign you all into breakout rooms, and we did say 15 minutes at first, but I'm going to lower it down to, let's say 12. So we have 12 minutes to discuss the following. So what are the main barriers to streamlining in your MDTs? And discuss those in your groups, and also suggest some solutions as well. What I'll do is we'll also pop the question into the chats as well. actually going to steal the idea from Caitlin Namanthi from Gosh and do the chat bombs, and you guys seem to really like them, so we're going to do that as well. So could you all please write your barriers in the chat and then not send them? So just write them in the chat, but don't hit send. And my colleague Matt is very helpfully going to help with reading out the responses. So we'll give it a few seconds.
You're on the phone all day?
No.
Huh?
No.
On the speaker.
All right. Do you want to, is that enough time to hit send? Does everyone hit send now?
Go.
Sorry, tell me not typing. Yes,
Bom,
please
bom,
hit send.
So a lot around time, which I guess is not a surprise, and I think something for us to take away and see if we can find some examples where people have managed to overcome that. Yeah, non-engagement. I think it's interesting to hear from Karen earlier. I think about starting, like choose the people that I want to, and make changes, and then often that brings people onto the journey. Find those first and actually second movers. There's often people with ideas, but you need one or two people to back them up and go with them. It can be really important. So getting those people and working out who they are can make these things happen. That's what we got here. Yeah, consultant leadership, like having dedicated consultant leads. I think having clinical leadership is obviously crucial with this, and if you don't have that, I think that's the first thing to try and tackle. Trying to do it without that, I think, is impossible, really. Yeah, old habits, difficult to break. I think that's really, like, change is hard. Getting people to shift, and especially with something as important as NDCs, that the mindset. It was interesting. Listen to the conversation with the questioner. So I've forgotten your name about this shift of where we had to talk about everybody to now that's actually is it okay not to talk about some people. That is a big thing to get over, and it's a question. When MDCs first came about, there was obviously concerns around different clinical decisions being made, and then we've through a lot of work that's obviously changed over the last 10-15 years, but that's quite a big thing to change and to move. So being honest about that I think is really important. So yeah, thank you for that. Some obvious ones. I think time and resources are always going to be a big factor in this, but as I think there are some things that can be done that I can hopefully, where those things are minor considerations, there are obviously some that you do need time in, and hearing from leads there about they're starting to be able to get that buy-in from their exec colleagues. Stuff I think is important. So using the remix you have, like cancer, if you don't have a cancer board, that's something that organisations should have, and if they don't, talk to your lead cancer clinician about setting one up, because that should give you a route to executive leadership to discuss some of this stuff and why it's important. Cancer, and a lot of the work that we do is a huge priority for organisations, but not necessarily is it got this established governance and that other sort of aspects of intensive care have. So try and use those to your effect. So do you want us to move on to
Yes. So yeah, the next thing is if everyone could write their solutions in the chat, but also not just send them just yet. I'm not very good at timing these. I feel like Caitlin and Anthony have it down so good, but let's give it 10 seconds and then.
So we'll have to PDSA cycle it to get it better for next time.
Yeah. Could everyone pop in their solutions into the chat?
I would really like some kind of bomb explosion thing on the screen.
I know. I'll make it look prettier next time. Again, I'm gonna take tips from Ked and Lampy on this one. Thanks, guys. You've really helped us with the new technique.
Yeah, so I mean, simple things like robust SOPs are really important. Yeah, they can take a bit of time and effort to create, but they can be really helpful. Yeah, working on these changes first, really sensible. Yeah, utilizing the technology, mini MDCs. I'm quite interested about what a mini MDC is. I'd like to ask someone to explain that. Yeah, I mean, I think support for interesting. I think, from my experience of working with regions and stuff, people are very switched on to the fact that you need to do this stuff properly. So you should hopefully receive support from our colleagues across the country. Yeah, using good information technology. Focus on yeah, that's a really good idea. I mean, to just really focus down on the complicated cases. Yeah, reviewing job plans. I mean, I think it's really important that, job plans are the backbone of obviously consultant workforces, and it's right for you to be able to challenge and suggest that these things might need to change to incorporate some of this work. Great. Let's look at anything else I've missed. Yeah, so that's kind of thing, like small change, celebrate success. I think that's really important. Small the So the challenge with cancer, obviously, it's fast paced and things expected to move quickly. But the benefit is that when you do make a change, you can often see it quite quickly. And so, being able to celebrate that and not have to wait lots of time, and also knowing if something you've done is not working and you need to roll it back is also quite positive. There's no problem with failure. I think it's, we sometimes get our best ideas from trying something that doesn't work. Yeah, thanks, Georgina. Yeah, I think that's a good tip. Finding ways to motivate people and get that engagement, have to take one thing at a time, working it through can really build that momentum. Starting something small, something often there is something small that is annoying to people and can be changed relatively quickly with a bit of effort. Doesn't necessarily cost lots of money to do. When you do that, and people are like, okay, right, people are listening to me, and maybe you get more engagement. And that can often bring dividends. Cool, thank you for that, everybody. I hope those sessions were helpful. I think it's good. Often I feel with these things that that we get a lot of benefit from the conversations, the questions that people bring, and the conversations you have to each other, as well as just the presentations we've heard, which have been fantastic. So hopefully that was useful for everybody. I'm already 2 minutes over, so I better head back so we can let people know.
Thank you so much, Matt. And thank you so much, everyone, for engaging with this as well. And thank you to Caitlin, Nawanthi, Karen, and Nikki for presenting. Just a little reminder of our next learning session. So our next one will be on the 4th of November, and that's part 2 of our streamlining session. And yeah, just a reminder of the other sessions as well. If you do need the invite, please get in touch. But yeah, thank you so much, everyone, for coming along, for engaging and taking part. I think it's been really great to have these discussions, and hope you've had some really thoughtful discussions in your breakout rooms as well. Thanks, everyone. Take care.
Thank you all.
Thank you. Bye.
Thank you.